This talk is about electrocochleogram. It is intended for the Nicklaus Children's Hospital Neurophysiology Fellows. The first section will be presented in a conversational format. Most clinical neurophysiologists feel somewhat stressed when talking about electrocochleogram. The main reason for this uneasy feeling is that we do not use it frequently and nor we know what to use it for. So without further ado, I will tell you what I think electrocochleogram is good for. I think electrocochleogram is useful to a neurologist in three infrequent situations. The first situation is when we have trouble identifying wave 1 in a brain auditory evoked potential study. These waves presented here do not represent one of those situations, since, as you can see, wave 1 in the brain evoked potential is very clearly identified. But you can imagine the contribution that having an electrocochleogram can make by just looking at the size of N1 and noticing the scale that is being used. Also, you can imagine its contribution by noticing that the peak of N1 in the electrocochleogram coincides with the peak of wave 1 in the brain auditory evoked potential, which, as you can see, is quite smaller despite the fact that the scale being used is different. This difference in size makes N1 a useful landmark to measure N1 latency, which corresponds to the latency of wave 1, and to measure the latency to peak 5, and to measure the 1 to 5 interpeak latency. The second thing an electrocochleogram may be helpful is to distinguish cochlear from retrocochlear causes of hearing deficit. Any lesion that occurs after the spiral ganglion neurons will not affect the electrocochleogram N1, but may affect wave 1 of the brain auditory evoked response potentials. The third thing electrocochleogram may help a neurologist is to diagnose unilateral Meniere's syndrome and follow treatment response to this condition. Suffice to say at this point that the structure labeled SP, which stands for summating potential, which we will describe in a few seconds, has an increased amplitude in patients with Meniere disease, as you can see in this frame by comparing the drawings and the waves below Meniere's disease and those below normal control. This ends the conversational format section, and now I will start with a question and answer format. The first question: which of the following is not true regarding electrocochleogram? A. Montage AEM to earlobe. B. LFF 5 to 10 Hz. C. HFF 2 to 10 kHz. D. Best done with regular EEG electrodes. Electrocochleograms can be obtained with surface electrode or with needle electrode. The surface recording is done with a special type of external electrodes. These electrodes, as you can see in the right side of this frame, are introduced in the external auditory canal by an ENT using pliers, and it is placed at or close to the surface of the tympanic membrane. The montage that we use may vary, but usually the external auditory meatus electrode is referred to the earlobe, or it can also be referred to ZZ. The ground electrode is usually placed at the forehead. The clicks used may consist of rarefaction or condensations. Click frequencies may vary from 8 times per second to 150 times per second. A total of about 1,000 trials for each individual method of collection should be used. That is, rarefaction at 8 per second should be averaged by 1,000. Rarefaction with 150 per second should also take 1,000 trials, and so on. The cutoff for the low frequency filter should be set at 5 to 10 Hz, and the cutoff for high frequency filter at 5 to 10 kHz. The amplitude of the potential varies with the location of the registering electrode. When the registering electrode is close to the tympanic membrane, the amplitude is usually 5 microvolts. So the answer to this question is D. Next question. Electrocochleogram occurs precisely between dash milliseconds. A. 0.1 and 3. B. 1.3 and 10. C. 3 and 10. D. 10 and 20. Auditory evoked potentials have customarily been divided based on their latency into short latency auditory evoked potentials if they occur between 0.1 and 10 milliseconds, middle latency potentials when they occur from 10.1 to 50 milliseconds, and long latency potentials when they go after 50 milliseconds. Short latency potentials are further divided into electrocochleogram potentials, which occur between 0.1 and 3 milliseconds and are generated by the hair cells and the spiral ganglion neurons. Brain auditory evoked responses starts after 1.3 milliseconds. They never do so before 1.2 milliseconds, and in normal adults they last till about 8 to 10 milliseconds. Brainstem evoked potentials start with the excitation of the spiral ganglion neurons and traditionally are recorded all the way to the inferior colliculi. So the answer to this question is A. Next question. All the components of electrocochleograms are receptor potentials of the cochlear hair cells. A true, B false. I hope you got this question correct because I just gave you the answer a few seconds before. Electrocochleograms last for up to 3 milliseconds. They are obtained by monoauricular stimulation and ipsilateral recording, at times referred to CZ. They originate in the cochlea, where movement predominantly of the inner hair cells trigger a sequence of events consisting in the production of a receptor potential in the inner hair cells that produces a flare of brief negative and positive potentials, considered by some to be the alternating current component of the receptor potential. It is interesting that since cochlear microphonics are a purely receptor potential, it is not affected by cranial nerve age pathology. So preservation of cochlear microphonics in the presence of abnormal auditory nerve action potential indicates auditory neuropathy. This is also referred to as retrocochlear hearing loss. The second component is called summating potential. It also originates in the hair cells and is considered to be the direct current component of the receptor potential. The third component is the auditory nerve compound action potential. This action potential never occurs before 1.2 milliseconds. So the answer to this question is false. Next question. Which of the following elements change polarity as the result of changing click polarity? A. Cochlear microphonics. B. Cochlear summating potential. C. Auditory nerve action potential. D. All of the above. The first component of the electrocochleogram, that is cochlear microphonics, varies with changes in polarity of the click. The second component of the electrocochleogram, that is the summating potential, does not change polarity with changes in click polarity. Auditory nerve compound action potential, the third component of the electrocochleogram, does not vary with polarity. In this frame, I have listed the three components of the electrocochleogram. Now I have added the waves present in an electrocochleogram with their corresponding color, as you can see in this frame. The top waves result from using rarefaction clicks. The bottom waves by using condensation clicks. In this frame, I have enlarged cochlear microphonics, as you can see, demonstrated by the aqua arrow cochlear microphonics are out of phase, whereas the summating potential and the auditory nerve compound action potential are in phase. So the answer to this question is A. Next question. Which of the following should you do to eliminate cochlear microphonics. A. Add rarefaction and condensation. B. Subtract rarefaction from condensation. C. Increase stimulus rate. D. Any of the above. You can see in this frame the electrocochleograms obtained by rarefaction on top and condensation on the bottom. The number after N indicates the number of trials. The waves were collected using ZZ as a reference. The legend on top indicates the different components of the electrocochleogram, which, as you can see, I have superimposed on the electrocochleogram's waves in this frame. Were we to subtract the wave obtained by rarefaction from condensation, which equates to inverting one of the waveforms and putting them together as I have represented in this frame by inverting the wave corresponding to condensation, we would see an enhancement in the visibility of the cochlear microphonics, while a significant decrease in the visibility of the summating potentials and the action potential. The changes brought about by this operation is the consequence of microphonics obtained by rarefaction and condensation being out of phase with each other, and the summating potential and action potential obtained by rarefaction and condensation being in phase with each other. On the other hand, were we to add the waves generated by rarefaction and condensation, as you are seeing in this frame, the microphonics would become barely distinguishable, while the summating potential and the action potential would increase in size. So the answer to this question is A. Next question. Which of the following elements does not change with click polarity changes or stimulus frequency changes? A. Cochlear microphonic. B. Cochlear summating potentials. C. Auditory nerve action potential. D. All of the above. Cochlear microphonics have different polarities when elicited by rarefaction than when elicited by condensation. Summating potentials have the same polarity when obtained using rarefaction or condensation. The amplitude of the summating potentials do not change with increasing frequency of stimulation, nor do the latency changes with increased frequency of stimulation. Action potentials have the same polarity whether obtained by rarefaction or condensation. Amplitude of the action potential decreases with increased click frequency, and increasing click frequency delays the latency of the action potential. Let's look at this in more details. As you remember, and it is depicted in this frame, only cochlear microphonics change polarity by changing click polarity. That is, cochlear microphonics obtained during rarefaction and during condensation have different polarities. And as we have just mentioned, by summating the waveforms collected during rarefaction and condensation, microphonics would become barely distinguishable, while the summating potential and the action potential would actually increase. In this frame, I have represented the wave so obtained, that is by adding rarefaction and condensation. At a stimulus of 8 per second, I have now highlighted the segment of the wave corresponding to the summating potential in this frame, and the action potential in this new frame. Now I have introduced the wave obtained by the same methodology, but at the rate of 168 stimulus per second. And again, I have highlighted the segment corresponding to the summating potential and the segment corresponding to the action potential. So you can see that increasing the frequency of a stimulation does not change summating potential's amplitude, nor it changes summating potential latency. Whereas the action potential amplitude at 8 Hz and at 168 Hz has significantly changed. The amplitude of the action potential has significantly decreased. The peak latency of the action potential has increased, as you can see in this frame. This maneuver may help us distinguish the wave that results from the action potential of the spiral neurons from those that corresponds to the summating potential. So the answer to this question is B. Just to finish, let me remind you why it is important to separate the different elements of electrocochleograms for a clinical use. First, to identify brainstem auditory evoked potential wave 1 in difficult cases. 2. To separate cochlear from retrocochlear abnormalities. And 3. To support the diagnosis of Meniere's disease. Thank you very much for your attention.